the County School Board to order. Ms. Aller, please take the roll.
Ms. Chen.
Here.
Mr. Hodges.
Here.
Mr. Hosang.
Here.
Mrs. Hunley.
Here.
Mr. Riffle.
Here.
Mrs. Donner.
Here. May I have a motion to approve the agenda?
Madam Chair, I move to approve the agenda as presented.
Thank you, Ms. Chen. May I have a second?
Second.
I'll give it to Mrs. Hunley. Ms. Aller, please take the vote.
Ms. Chen.
Aye.
Mr. Hodges.
Aye.
Mr. Hosang.
Aye.
Mrs. Hunley.
Aye.
Mr. Riffle.
Aye.
Mrs. Donner.
Aye. We will now move into the budget work session. I believe Mrs. Hunley has a disclosure to read.
Yes. As a member of the school board of Williamsburg, James City County, I acknowledge that I may have an interest in the FY27 school budget because my husband is an employee of the WJCC schools. However, I believe that I am able to participate in the consideration of and vote on the budget fairly, objectively, and in the public interest.
Thank you, Mrs. Hunley. Dr. Keever, I hand it off to you.
Madam Chair, thank you very much. This is Budget Work Session 3 as we move towards releasing the superintendent's budget on February the 3rd. There are 3 things in Budget Work Session 3 that we want to get accomplished. And the first thing that we want to do is to hear directly about healthcare trends, both nationally and across the Commonwealth. And we've brought in an expert in that, and I'll introduce Greg in just a second. The second part that we want to do this evening is to look at healthcare within WJCC. And then the third item on our list of things to talk about this evening would be what we promised that we would give you last week when we were together, which is a summary of, in total, what are some of the dollars that we're talking about as we think about the operating budget for fiscal 27. Leading us off this evening is Greg Snow, who is with us from USI. We've been working with USI really closely over the course of the last year plus as we transition from one healthcare plan to a new healthcare plan. And Greg is here, and over the next 10 or so minutes is going to give us some overview in terms of healthcare trends so that the board has a firm understanding of some of the challenges that we are facing as an organization. Greg, welcome and thank you.
All right. Thank you, Dr. Keever. Mr. Donner, thank you. And ladies and gentlemen of the board, thanks for having me here today. Please don't hold my last name against me with the impending weather coming. I'll try to do my best with it. Just an overview. I was asked to just go through trends, and I'll probably make some comments what's going on regionally. There's a lot of headwinds that we're seeing this year and into the near future. If we go to that's forward, yay, I got it. And my new glasses, so I think I can actually read the board that I couldn't yesterday. Technology improvements, we've heard this one for a long time. New technologies are always coming out. They are very expensive. Pharmacy, we're seeing pharmacy trends in double digits. A lot of new specialty drugs on the horizon, hundreds on the horizon for FDA approval. Your drug spend is pretty high, so certainly you're being impacted by it. Increased usage, I'm actually seeing the number of scripts per employee go down, but we're just seeing more expensive drugs. Aging workforce, unfortunately, we are an aging country, and as we age, we have increased risk and higher cost claims. Administrative costs, this is really sort of a post-COVID. We have really seen pressure that the hospitals have been facing with staffing and nursing shortages. So obviously they've been coming up with financial incentives. They've been negotiating higher increases with the healthcare carriers around the country and in the Commonwealth here and locally. So you're not immune to that. Consolidation amongst hospital and providers, we continue to see, and I guess a good example of that, if you look at Centara, they have consolidated with many hospitals around the state. Less competition just means higher costs. We like competition. Plan design leveraging is one you probably haven't heard of before, but as your plan design stays the same year over year, and you see medical trends increasing at double digits, and right now we're seeing medical at close to 10%, prescription drug at 11% or so in annual trends going forward. When your plan design doesn't change, you're just picking up more of that cost year over year. Doesn't mean you should change your plan design, but I'm just pointing it out. We are certainly seeing cutbacks from the feds in Medicare and Medicaid. If you talk to Centara or Bon Secours, they're talking about very big dollars that they foresee coming in cuts. When the federal government cuts out, it just shifts it to us as consumers. The hospitals are going to make it up, so they're going to negotiate with these carriers for higher reimbursement levels. So that's certainly a trend that we're seeing. And then we're not really sure where we're going with federal policy. Tariffs still have somewhat of an unknown, but as you know, we do import a lot of ingredients for drugs from around the world. And if those ingredients are tariffed, then our drug costs are going to be higher. So we're keeping a close eye on the federal legislation that's coming down the pike. As that does impact us, we'll certainly be reaching out to you all and letting you know. Oops. A couple other points on the state of healthcare. We are seeing the number of individuals with large claims, and I'm talking about 100,000, 300,000, or even folks with 2 or 3 million. If you look at the number of individuals with $3 or more million in claims this past year, that has doubled in a year. We are seeing an increase in large claims across the board for all of our clients, and a pretty significant increase in those. So that is certainly putting pressure on all of our clients when it comes to driving your healthcare costs. Post-pandemic, we talked a little bit about contract negotiations, tariffs, pharmacy. A new term that I'm sure you've probably heard about is these GLP-1 drugs for diabetes and weight loss. The carriers do not cover GLP for weight loss on their fully insured business, and most self-funded clients don't cover it for weight loss either. You all do cover it because it was covered before under the local choice plan, and we were trying to make a transition and weren't making changes at that time. But GLPs are driving costs, I think for you all, close to like 9.5% of your total cost. Not just your prescription drug, but total cost. I don't think there's a consultant in the country or an actuary that saw that coming 3 years ago. The impact's been huge. And we anticipate to see more and more folks taking those GLP-1s. I've heard stats saying 50% of Americans are going to be on them in the next 3 years. So we'll talk a little about strategies around that. And then behavioral health. That is certainly post-pandemic. We are certainly seeing a lot more in behavioral health claims, and behavioral health does impact other areas of claims. Or if someone has cancer, they certainly are going to have some behavioral health issues. So we're seeing more and more behavioral health services being offered by these carriers to help combat the increasing cost on behavioral health. Just a little bit of a trend graph. Historically, medical is in that dark blue. We saw a big dip during COVID because people just couldn't get out to see doctors, but the impact of that probably now is we're seeing some more severe cancer cases that have been left undiagnosed post-pandemic. And I mean, we're seeing those costs that could have run 75 are now running 200,000 or 300,000 because they're stage 4 versus stage 1. That far right, the 226 projected, that's 11% prescription drug, 9.3 on the medical. I can tell you regionally, we have a lot of clients are in double digits. We have a lot of clients in the teens, 15, 16% increases that we're seeing that we have not seen in some time. So there's a lot of headwinds, and we're seeing increases on many of our clients across the board and regionally. So it's a little bit of a concern as we move forward. We don't like to see trends like that. A little bit about health condition trends. Certainly you can see there cancer is impacting a lot of our clients, and it seems to be cancer is regionally here. We see more cancer than we do in other areas of the state. Not sure why, but we do. Musculoskeletal, it's probably related to the fact that we're an aging population. That's impacting our costs. Cardiovascular, diabetes for sure. autoimmune, you can see on the bottom far left of the chart, we're starting to see autoimmune pop up much more significantly than we had in the past, which is interesting. So just some of those different areas that we see are impacting cost study, and you're really no different. We have very little data right now on your plan because you just went self-funded directly with Anthem October 1st. As we get more and more data, after you have a full year of that data, because we cannot get any of the data from Local Choice, unfortunately, to import into our data mining tool because they won't provide it. So we're going to keep getting data as you're with Anthem here direct, and as we get out a year from your original effective date this past October, we have very granular data, and we'll be able to dig in to see what are the cost drivers behind your plan. We have a little bit of knowledge on that now, but we'll have more and more knowledge as we get more data. Any questions yet? Yes.
Can you clarify, okay, so the GLP-1s, is that for what we see here, obesity, or is it for the diabetes?
For both, there's GLP-1s for obesity, which are typically covered. I don't know, but it's not covered, and the carriers covered it also, even fully insured. But the ones for weight loss, that's the one that's really impacting folks that are having that coverage in their plan. But carriers do not cover GLP-1s for weight loss under their fully insured book of business, and most self-funded clients are not covering it. Part of the reason, if you look at GLP-1s, about 60% of the people stop taking it in the first year, gain all the weight back that they had. So to really be effective, and I know we're working on a wellness plan, and this would be part of that, is what can we help with behavioral health services to help folks on their weight loss journey so that they can develop habits. Some of it's habits, some of it's behavioral, some of it might be mental, that we can work through to help those folks, bring their weight down and sustain it. We don't find the GLP-1s work for a lot of people, and they're extremely expensive.
We'll give you a little bit more specific detail later in the presentation from Emily and Renee.
Okay.
Okay.
Wellness trends, you can see increased member utilization of obesity treatments. Higher prevalence of cancer, that we've talked about, that increase in surge treat mental health. I think those are things we've talked about already. It's just a chart. I'm not going to really spend any more time on that unless you have a question. Early detection of cancer. This is why cancer is so important. If you look at early detection, colorectal is a really good example. If we can get that in stage, what did I do? In stage 1 versus stage 4, you can see the cost impact, but then look at the survival rates. This is why you want to catch things in the early stages. And during COVID, folks really weren't getting these early detections done, and we're certainly seeing the impact of that still today. So really, early detection, this will be part of your wellness program in building awareness, what programs are out there for employees to access, and then possibly building incentives around folks getting those services done.
Because I think if you look at that chart and you look at the screening costs and then look at the treatment costs, our goal would be to help people understand and our staff understand the importance of the screening mentality through our wellness programming. So A, we can help you understand what's happening, and then B, work to address it sooner versus later. And I think that one of the things we've been very excited about and moving to our new plan is really a focus on the wellness aspect and being able to utilize some funding from Anthem to help drive some of that.
Yeah.
And again, Emily, and we'll talk about that a little bit later when we get into some of the WJCC specific items.
Oops. I go in the wrong direction.
You are.
There we go. Mental health. We're seeing this, and I'm sure you're seeing the impact with students too. Mental health has really been an issue post-COVID. And if you look at our book of business, 16% of our members in our book of business, which is about 2.8 million lives on self-funded, are being impacted by mental health. You can see 9% of cancer patients. People get depressed when they have severe cancer. It's understandable. It's number 7 in our book business. Then the average pay per episode is about $4,000. And I think this number is low. I think more folks are on antidepressants than we even see reported. I think you see that certainly in your student population too. So this is a growing area of concern. We have seen mental health costs. Fortunately, we had mental health legislation years ago that is treating mental health the same as other illnesses, which is good. Of course, avoiding major depression, it's expensive. It impacts everybody. It impacts the person, their family, you all, your staff, teachers, other students, everybody. And if we can get to that in an early stage, again, there's programs offered by Anthem that help folks through these issues. So if we can get to those folks and build some strategies around that in your wellness program, we would like to do so, because it really is a major impact on people. If I break a leg, it doesn't really impact other folks, but if I have major depression, certainly there's a lot of people impacted by it. Pharmacy trend, 24% of healthcare was spent in pharmacy in 2024. Your pharmacy costs are running 44% of your total. Your pharmacy costs are very high. A lot of that is specialty. A lot of that is GLP-1s. Your GLP-1s are running about $2.8, $2.9 million annually right now for you all. The GLP-1s for weight loss are running about $1.5 million for you all currently, and you have about 138 people that are taking GLP-1s for weight loss. There are opportunities to reduce that cost for Williamsburg James City Schools by about 75%. There is the direct-to-consumer pricing now, which I think, are you going to talk about that a little bit? Okay, I'll leave that for Emily and Ray to talk about. So there is some ways to reduce that cost significantly, and I would encourage you all to look at that closely. Reinsurance trends. Again, we've talked a little about the number of folks. On this slide, you look at the doubling of folks with $3 million plus in claims. I just looked at a report from Symetra Life, who's one of the largest reinsurance carriers, and 24 over 23. I haven't seen 25 yet because they're still getting their numbers together. If you look at the number of people per thousand that had claims above 100,000 or 150,000 or 200 or 300 or 350, the number of individuals are increasing by 25% year over year. That is a huge impact, and it is certainly putting a lot of pressure on reinsurance pricing, because you do purchase reinsurance. So anybody on your plan that has a claim in excess of $200,000, Anthem writes that amount above that claim off. You pay a premium to Anthem for it, reinsurance premiums, but we are seeing a lot of pressure in the reinsurance markets because the number of individuals having large claims. And then you can see the medication. I talked about this a little bit earlier, the number of scripts for cell and gene therapies, infectious disease, and cancers. Those are in development. Those are big numbers, and they're very expensive. So a little bit on self-funding, sort of as a reminder, last year, you all made the decision to go to Anthem Direct, terminate local choice. There was a lot of reasons to move in that direction. Most large employers that have 500 employees or more are partially self-funded. All of mine are. I've never had a client go self-funded ever go back to fully insured. Over time, self-funding definitely benefits you as an organization for many reasons. You eliminate a lot of the carrier margin. So in years of good experience, you benefit from that because you hold your claims. So if you have a better year than you expected, your costs are lower. When you're fully insured, they're higher. You have a better ability to negotiate with the carriers when you're self-funded. The new Anthem plan provides you flexibility in plan design and contributions that you did not have under local choice. You were very limited on both of those. Data reporting, I mean, we got very little data out of local choice, some data they refuse to provide. We can't get your historical data to build into our data tool because they won't provide it. So we're getting that data now that you're with Anthem. That gives us insights to your cost drivers, and it helps us work with Dr. Keever and his staff to develop strategies to help mitigate trend. And that can be numerous different strategies, even up to looking at on-site clinics and possibly pharmacies, which can help mitigate costs. And then certainly your enrollment for both your staff and your employees' experience with going direct with Anthem, with what we were able to do with helping educate folks and communicate with them and have enrollment counters on site. It greatly enhanced that experience for your employees and for your staff, and it will continue to do so in the future. Any questions on self-funding? Okay. Options, some of these are, well, what's new is old. I mean, plan design changes, obviously that reduced costs, it does shift costs to your employees. Contribution changes, again, that is a shift, but it is a way to reduce cost. Wellness and disease management engagement, and I don't mean just putting in a program, but building in probably some incentives that we can get your employees engaged in the wellness program so that they are truly improving their overall health, which can help mitigate trend. Removing GLPs for weight loss and steer employees to the direct-to-consumer. You'll hear more about that. You can increase your reinsurance limits to help reduce your reinsurance costs. Other things to help reduce costs, some of them are pretty, I won't get into, but they don't fit public sector very well because they're very, very disruptive to employees. But you might hear about some things. If you ever do, just reach out to me and I'd be glad to talk about it to you all.
It was important from us, from our perspective administratively, to hear from Mr. Snow, who has a broad reach and a wealth of background in terms of health insurance. Even today, I heard from an employee on their health insurance costs and desire for us to continue as an organization to look for more affordable health care. And that's something that is on our minds all the time. Sadly, I'm not sure that there is a more affordable health care process. And so I think we are doing our level best to help provide insurance, strong insurance for our employees, and recognize that each person has their own individual unique circumstances that drive their healthcare needs. So are there other questions for Mr. Snow before we transition into some information on our current state?
No board members? Nope.
Greg, thank you. We really
Thank
appreciate
you so
it.
much.
The next feature of our conversation this evening is to really look at some of our current numbers and data associated with our plan design now. As Mr. Snow mentioned, we did transition to Anthem last year. We have several plan designs at different intervals that Emily will talk about in terms of some of those numbers. Talk a little bit about what our renewal rates have tended to look like over the course of the last few years. We'll answer some questions on that, and then once we finish up on that portion, we will shift gears into some summary totals in terms of the budgeting process. So Emily, welcome.
Thank you. Good evening. So this first slide shows our current health insurance rates for the 25-26 plan year for our Health Keepers 500 plan, which is our most expensive plan currently. So you can see the total premium cost for employee only, employee spouse, and family tiers, as well as the employer and employee shares. So the total is in the green bar, and then you're seeing the employer share in the blue and the employee in the lavender bar. So for employee-only coverage, the total cost is $1,073, of which the division is contributing $824 a month, leaving the employee share at $249 monthly. The other tiers also include an employee and employer share. The second plan option is our HealthKeeper 750, which is our mid-range and most popular plan with slightly lower total premiums. Again, our employer contributions remain consistent across the tiers. For example, the employee-only premium is $955 total, and the employer is contributing $824 a month, with the employee responsibility being $131 a month. So this is providing employees with different options depending on what their need and preference is. And then finally, our third option is our HealthKeepers HSA, which is also our high deductible plan. So this is our lowest cost plan and represents the high deductible plan option. So here the employee only rate is $755 monthly, with the employee share at $47 a month. In addition to the rate share you see, we also make a monthly contribution to a health savings account. So these various plan designs are offered to provide our employees with multiple options depending on their coverage needs.
Before we shift to the next slide, let's see if there are any questions around. So these are our current 25-26 plans. We, as Mr. Snow mentioned, our plan year runs October 1 and concludes on September 30. As we continue in this budgeting conversation, we are using placeholder percentage of a renewal rate increase that we hope is lower, frankly, than the number we'll share with you this evening. Additionally, the plan designs are also things that we continue to work on refining, because the cost sharing scenario from the employer side and the employee side are things that we need to get within a certain number. And that certain number we're going to share with you as we get a little further along. But I wanted to see if you had any questions around these three levels.
No, I'm not seeing any questions.
Okay. Emily?
This chart outlines our historical health insurance premium increases dating back to 2014. As you can see, the division has experienced fluctuations over time. Last year, the plan experienced a 5.4% increase as we transitioned away from the local choice. Had we stayed with the local choice, the renewal would have been 6.7%, with the HMO plan in that consortium experiencing a significant increase of 21%. So these trends are aligning with the healthcare costs nationally that we're seeing. So we're kind of in line with everyone else, unfortunately. Looking ahead to 26-27, we're currently estimating a 16% increase in health insurance costs based on early utilization data. A 16% increase equates to roughly a $3.8 million addition to our budget. So this slide illustrates possible cost sharing scenarios between WJCC and employees, for example, a 60-40 split or a 70-30 split.
Let's pause there and see if there are any questions before we talk about cost savings.
Yes, Mrs. Hundley.
So when employees talk about they got a raise from us, but then the health care went up, do we have an average? Like, are they talking the $200 they were out of, or is there like an average range so that we know? Do you know what I'm saying? They always say,
And I think I've heard the same thing.
Yeah.
I think if you go back 2 or 3 slides, Emily, just so that we can look at some of the different plan options. It is difficult for us to say with certainty. We could tell you exact numbers after an employee makes a selection about his or her health care, whether or not they're going to go by themselves, whether they're a +1, or whether they're a family, and then which of the 3 options they choose. So you've got multiple variables, and then we can look at what their salary is and their health care choice to then determine, are they seeing their full raise? Are they not seeing their full raise? So it's very difficult employee to employee to say, in general, it's X. We can do that generally with raises, and we can say, in general, all employees will receive X percentage, because we can look across the entire chart. But in this case, because it is so individualized, it becomes very difficult. I don't doubt employees when they tell us that their health insurance rates have gone up and they are seeing less money in their pocket as a result. I get that. I also say that each of us has our own individual choice to make in terms of our healthcare and our healthcare needs, and we have to balance that as an organization with each individual employee's right to make that decision. So one of the things that we attempt to do, and we'll try to do this for the board as we get later into the month of February, is to project out if we take a rate increase and we include that rate increase with our current rates, and we look at a projected salary increase, and we look at several different employee types, we will do the best we can to model a best case, worst case scenario. We're not quite ready to do that yet, but it does give you in general a sense of, is there an increase in compensation overall? Is it a modest increase, or is it a potential net loss based on what the employee selected? Does that help? Try to answer your question.
Yeah, a little bit. So, but employees can't do that. Like, are they able to go in and take their salary with the increase and then put all three different scenarios, if they take this one, and this one, to know in advance so that they know? Can they do that? Or is that when the person comes here and sits down with them to talk them through that?
I believe that was an option when we were doing the individual counseling sessions as employees were picking their plan designs to make those decisions, because it would tell you like what your monthly costs would be. And so, if it were me, I would compare that monthly cost to my current monthly cost, and then I can figure my salary out by multiplying it by, 0.02 or whatever my raise was. So yes, I believe that's available. Invariably, it's still not going to feel great because there is likely going to be a rate increase, and if your insurance needs remain the same and you pick the same plan that you're on, there's likely a rate increase, which means that it's going to be more expensive per month. And I'm not sure how else to say that without just saying I understand that it's frustrating. Part of the reason it was important for us to have Greg here this evening was we are not alone in that scenario.
Okay, thank you.
Mr. Hosang. Yes, Mr. Snow and then Mr. Hosang.
Just a nuance, when you look at employee contributions, remember that they are taken pre-tax. So for that employee only, that $131 probably is about $98 out of their paycheck. So just remember, when you're talking about cost, those are the total costs, not what they truly are in their take-home pay.
Thank you, Mr. Snow. Mr. Hosang.
I'm not sure how this is going to come across as a question, but in your slide 6, you have an estimated increase of 16%. In the previous presentation that we received, we had
15%.
Oh, well, I'm looking at something different.
Okay.
I'm looking at slide 4, the previous presentation, where there was a medical trend increase and a pharmacy trend increase, 11%, 9.3%.
And I believe that's
So
talking about
is-
inflation. I believe that's an inflation rate.
So is the 16% encapsulating both basically the healthcare and the pharmacy costs that we're looking at?
I'll let Greg answer. My understanding is that it is a renewal rate increase in total of 16% that we should budget for, or it's predictive. And part of that is predicated on only 3.5 months in our current plan year. So, Greg, correct me if I'm wrong.
You're correct. It is medical and pharmacy combined. When we're doing a projection this early, we have to take those trends that you were looking at, that 9.3 medical and 11 on pharmacy. We have to assume cost increase every month, because if you go to buy, as an example, a loaf of bread is going to cost more 10 months from now than it does today. So we have to build in all those additional months of trend. So those are 12 months of trend. Right now, we are so far out, we're building in, 22 months of trend? I forget what the number is, but your increase is really, trend is driving that increase when we have to project so far out. We will give an update. I'd like to get another 3 months of claims, and we'll give the staff an update on that. I hope things improve. I don't know if they will, but we will continue to update that analysis as we get more data and you get a little closer to your renewal. But you're right, we're seeing those type increases with large employers this year that we have not seen in quite some time. And it's not one or two, it's numerous ones.
In previous budget work sessions, Mr. Hosang, we've been using 15% as our placeholder for that dollar amount, and we went ahead and raised it this evening to 16% as a result of additional conversations we'd had with Mr. Snow. We didn't feel like 15 was enough. Mr. Hodges.
Yes, Mr. Hodges.
So looking at that 16%, kind of piggybacking off of that, that question, I guess, so this 16%, since you said, Dr. Kira, that this was previously 15%, this number is clearly a little bit fluid in what the actual total may end up being. So, you know, thinking very optimistically, there's a chance that this number could go down. But is it safe to say that this number, I know, very optimistically, but is it safe to say that this number, it's better to predict the worst case and then be able to kind of correct in the opposite direction if need be than to undershoot the estimate? Is that kind of what we're seeing here?
That's been our philosophy administratively in preparing budget documents and budget conversations. We feel like we need to give you what we hope is the worst case scenario, and if it comes in less than that, that's a benefit for potentially compensation, you know, lowering the rates, changing the cost share. I mean, there are any number of various pieces that could occur there. It would be worse for us to put you in a position to approve a budget in March and then need to come back in May and tell you we need to find another $2 million. I don't think we want to do that.
Yeah, for sure. Thank you.
I do have a question. So with these increased healthcare costs, and if we were to have a healthcare reserve fund, as we've talked about, with funds that get unspent at the end of the year, how would that impact our ability to support healthcare in these cost sharing scenarios?
Renee, do you want to tackle that for me, or would you like to correct me when I get it wrong?
I'll correct you.
She did it today already once. I think that what you would see is you would see us being able to potentially pull from the reserve to, in essence, buy down what the estimated increase is, which then would potentially lessen the total dollar amount we need to put towards healthcare as an organization. So there are any number of different things that could occur as a result of that. You could potentially shift the cost sharing model. You could potentially put some of that money back into compensation. You might lessen the amount you want to ask for from the locality. So there are different ways to model that. I think one of the things that we want to be cautious of administratively, as we just moved into this potential for a healthcare reserve, we want to actually build a reserve before we take from a reserve. And so it will be important, and Renee reminds me of this all the time, that we need to actually put some into reserve before we start spending that money. But our goal would be to control costs and to have some money available at the end of the year. We want to have good plan years. We want to talk about wellness. We want to talk about employees being healthy. And because of that, we are able to see the ability to check the rate increases. Is that good?
That's good.
Thank you.
So essentially, if we were able to have that healthcare reserve fund, so perhaps not for this plan year, but on out years as we continue to build that reserve, that would give us more flexibility to be able to be self-funding in some ways and not have to go to the localities with additional increases as our healthcare costs go up, because we have been able to at least mitigate some of those costs through our own reserves, which is money that we would send back to them. It's either kind of let us keep our money, or we're going to ask you for our money back in another way.
Yes, ma'am. And I think that we want to continue to be strong stewards of the public dollar, and we are looking to help control costs. If we have money available at the end of the year that we could put towards the healthcare reserve, that's terrific, because that allows us to be able, forward thinking, to continue to bring down costs for employees. So that would be the goal. And I'm hopeful that there is some amount, even as small as it may be, to be able to utilize this year based on some of the funds that we returned at the end of the last fiscal year.
Thank you.
It does see now. I'm being reminded by USI that it does take time, and we are very new in the plan. And I think and we talked about shifting from the local choice to Anthem last year. There is a possibility that we will still owe some money to the local choice as they finish out claims and as we sunset our relationship with them. We don't have the final amount. We are hopeful that we are on the plus side of the ledger versus the minus side, but at some juncture in the next few weeks, we will probably have a better sense of what that dollar amount is.
Thank you. Any other questions?
Let's just make sure that in thinking about the distribution of potential increase to employees, the 60-40 or 70-30, I just wanted to get a sense from the board in terms of where you are leaning on that as we continue to try to build out the op budget.
I'll give members a few moments to think about it. Yes, Mr.
What,
Jose.
what did we have last year?
Remind me, I think we went 70-30.
Yes.
We went the 70-30 split.
I believe we've done 70-30 the last few years, at least since I've been on the board.
I'd stick with that. Don't try to fix what's not broken. And it's gonna take more money out of their pocket too.
Just based on our calculations, it's about a $400,000 difference if we go 70-30 versus 60-40 in terms of the operating budget.
Yes, Dr. Cavazos.
That 70-30 across the board is pretty generous. I mean, I typically don't see that, but I mean, if we can keep it, that'd be great. And it should be, really emphasized because I can't afford that as a private employer. It's really pretty high. And we're having really a lot of difficulty with our insurance as well.
Thank you. Can I just, and I know it's hard to commit in this point, but just to help Dr. Keever, Ms. Ewing have a sense, kind of go around the room and say it. So can I start with you, Ms. Chen?
Sure. I'd like to see us, for planning purposes, at this juncture, I think keeping it at 70-30, I don't see a reason yet to move away from what we've been doing for the last few years. I know that the percentage increase is something that we need to be looking at in the overall budget, and if we need to, looking at places where we can sort of save, but I don't want to see it. I'm just not ready to say that I want it to be 60-40. I think I'm definitely leaning heavily toward the 70-30, just keeping it as it has been and what our employees have come to expect.
Thank you, Ms. Chen. Mr. Hossain?
At this point, I would agree, keeping it at the 70-30, but with the understanding that if there are other issues that come up as we go through the process, as there always seems to be, that this might be something to keep in the back of our mind, that to say that, hey, look, this might be the place that we could, quote unquote, save a little bit of money. So, but at this point, yeah, 70-30 to continue with what we've been doing.
Thanks, Mr. Hossain. Mr. Hodges?
Yeah, I tend to agree with Mr. Hosang and Ms. Chen that, if at all possible, keeping the 70-30 split feels like the best thing to do on behalf of our employees, with the understanding that, budget processes are fluid and that if things get tight, then, maybe we have to rediscuss this. But if at all possible, I think keeping it at 70-30 would be, should be one of the last things that we try to cut money from if it comes down to that.
Thank you, Mr. Hodges. Dr. Cavazos?
Well, from what I understand, from my experience, it's a truly generous split, 70-30. And so again, it would be a nice prize. And so if we can't give them that much more on the pay side, at least, keep them maintained on the health side, so they don't feel it quite as much. But I don't know how much longer we can keep at 70-30. That's extremely generous.
Thank you. Mrs. Hunley?
I agree with my board colleagues. I don't have anything additional to add other than the 70-30 is fine with me.
Okay, thank you. I feel likewise. I think we should keep it, but we also are still in the midst of the budget process, so we will see what happens.
Okay.
Mr. Riffle is not on the line.
Okay, got it. Okay, thank you. That's helpful. Let's talk about some of our focus around cost savings and looking at ways for us to mitigate some of the challenges that we are facing. And Emily, talk us through that, please.
Sure. So to help manage rising healthcare expenses, we're exploring several cost-saving strategies. These include limiting coverage for GLP-1 medications prescribed for weight loss, incentivizing early detection screenings, and evaluating a spousal surcharge adjustment. We are continuing to promote wellness initiatives through a wellness leadership committee and expanding employee education on available healthcare resources. So an example of that would be helping make sure employees are educated on how to use the mail order pharmacy, for example, to achieve cost savings from what they're paying monthly in a copay, because they can reap some savings if they switch their prescriptions over to mail order and have them delivered direct to their home. Using virtual care, we do have very good virtual care options through our Sydney app with Anthem, where you can see a virtual provider at no copay at all for a lot of things that are not necessarily even urgent care related. You can get connected directly with the physician. If you have a cold, a sore throat, you've taken a COVID test at home, find out you're COVID or flu positive, you can connect directly with a care provider that way and then eliminate the copay cost. So the GLP-1s, we've talked a lot about that tonight. So we are looking at some different strategies, maybe making their criteria for acquiring them more stringent, looking at different cost sharing, maybe sending people to the private market and establishing a reimbursement plan as far as that goes. So there's some different things we're talking with our USI consultant with on how we might be able to better manage those costs and still provide some kind of umbrella coverage or resource.
As we continue looking at some of the cost saving pieces, I just want to be sure that the board is supportive of us looking at prescription drug coverages and how we go about helping our staff and or those on our plan look for other ways to mitigate costs. Is that an area of continued support?
Ms. Hunley?
I have a question. I'm not real familiar with the GLP-1s. I've seen on TV all the commercials and they show the lady, usually a lady. And so you're saying that after you lose all the weight that you wanted to lose, if I understand you, Mr. Snow, you need to continue just to keep taking it, because if you get off of it, then you go back. So then you have more increased health problems because you went off of it. And then what have they done the studies on? What are the side effects? Like, what are you developing something else that's going to cost us?
Certainly, 60% of the folks discontinue it after a year, and then they gain the weight back they've lost. So ultimately, it hasn't really helped them. There are a lot of side effects with these GLP-1 drugs. Some of them pretty severe. You have gastrointestinal issues. You have muscle loss issues with the GLP-1. So certainly, there's some risks involved with those for weight loss. And the other big thing is that you saw an announcement probably a few months ago with the president with the direct-to-consumer pricing with some of the drug companies, which individuals can go out direct to the consumer and buy these drugs now go to a pharmacy but get it through a manufacturer at a greatly reduced price than what you pay as an organization for those drugs. You're paying maybe $1,200 a month now. It might be $350. So there is the ability for folks to go out and get those. So if you eliminate the coverage, they have options to go get that drug for $150 to $350, maybe $400.
Gotcha.
And I think you'll see those prices continue to come down. So there are options.
Thank you.
Does that Does that indicate some level of support for us looking at ways to mitigate some of the challenges with, I believe that based on what I've heard from Mr. Snow, our drug costs as an organization are significantly higher than like organizations. I think we ought to be looking at ways to be stronger stewards there and encourage our staff to look at some different methods, and just want to be sure that we're on firm ground with the board on that front.
One more question I was thinking, would that be discrimination on our part if these groups that we have that are developing to help employees, if the people that are on the GLP ones get off of it a year and then you design something for them so that the weight does not come back on, is that put us in trouble for discrimination, or is that okay? Is that,
You can develop programs, wellness programs and initiatives to help folks out. Nothing
Okay.
discriminatory about it.
okay, that's all I wanted to know. Thank you.
Yes, Dr. Cavalli.
Mr. Snow, I'm sure you're familiar with the oral forms, with the oral forms, not the injectable.
Yes,
And so Ortho came out with an oral, it's $149.
yes.
And Eli Lilly's upset because they didn't get to the market sooner. But I think that's gonna just in of itself, dramatically decrease the
It
cost of
dramatically
GLP.
drops that cost.
Yeah,
Not as effective as an injectable, but still an effective prescription.
yeah, obviously you gotta change a little bit of diet habit, but $149 versus $1,400 is a lot of moolah.
We might see that employers can get that price in the future, but right now you can't. It's a direct to consumer
Exactly,
price.
yeah.
Yes, Mrs. Jen.
Just to answer your question, Dr. Keever, I just want to say that I do think it makes sense from what I've seen presented tonight from Mr. Snow as well as the presentation so far. Just wanted to say that I'm supportive of you were asking for some feedback. And, when I look at the presentation from Mr. Snow on slide 10 with those recommendations, it does make sense. The healthcare costs continue to rise, and we have to look at some ways to be most efficient with our spending.
Okay. We have not talked a lot about increases to the spousal surcharge. I wanted to sort of gain perspective from the board related to that as well.
Well, I know I read my disclaimer, but when I was a spouse with my husband, it was really a nice, appreciative not to have to have to pay an additional fee. But of course, if we need to save money, but it is a bonus and I don't know how many employees we have that are married, but it was substantially a big difference if you did it the other way.
I don't know if we have the data in front of us on the number of folks that are paying the spousal surcharge now. And the spousal surcharge, correct me if I'm wrong, would be for those staff members who their spouse does not work for the school division, but works for another employer, and we bring them on to our insurance, and we.
Oh, okay, I'm sorry, I misunderstood.
you
I
might have
thought you
been-
meant you were cutting the one where,
No, ma'am.
okay, all right.
No, ma'am.
Okay.
I'm really thinking about and wondering about members of our team that have spouses that perhaps qualify for insurance through their employer and instead prefer to use our insurance, which we understand. There is a surcharge that is paid for that. I would consider it to be a nominal surcharge, but there is the possibility that surcharge could be raised as another way to offset some of the increased costs that are associated with healthcare. And before we started looking at modeling around that, was curious about board perspective.
Are those numbers on the beginning slides of 2, 3, and 4 where it's in the box on the top left where it says employee only and it looks like there are numbers?
Yes, those are the numbers on the enrollment for the 3 plans.
But that does not suggest the surcharge, the numbers that are
Right.
getting the surcharge. So Renee?
There are currently 466 employees with either family coverage or employee plus spouse, so they're paying that spousal surcharge of $75 a month.
I'm sorry, could you go back to slide 2, just so then maybe I'm not understanding. So what does that box on the left signify?
So we have employee, so employee only, like for that plan, it's 52. Employee plus one is the employee plus their spouse, but we have it split out. We have an employee spouse rate, an employee child rate, and then an employee plus children, and then a family rate. So we have multiple tiers that we're not showing every single tier of coverage.
But those are how many, that's the end though of how many in this particular one are employee only? Like that 52, is that?
52 is employee only on the Health Keepers 500. And then employee plus one in this plan is 22, and that is the spouse, the employee spouse plan. But the family is family and the children. So it depends on which coverage they have.
So then it looks like, for instance, for employee spouse, like we're picking up an extra. So the employee is picking up 400. And this is our most expensive plan that we're looking at, but we're picking up about, the employee's picking up about 400, but we pick up an additional 200 as the employer, on top of also taking the 70-30 increase. And we pick up almost $1,000 for the family as the employer in that scenario.
That's right. And so as we continue to think about and look at, we understand that health insurance is an important benefit. I want to make sure that I say that over and over and over again, because I recognize that it is. I think it's somewhere in the neighborhood. Our total operating budget, 12% of our total operating budget, or somewhere in that neighborhood, is devoted to healthcare and health insurance. That's a fairly hefty number. As we are really considering the resources that we have access to and our desire to continue to remain really strong on the compensation side. I mean, we've talked about this before, but when we have compensation increases and we apply it to all staff, everybody on the team receives that compensation increase. When we talk about healthcare, there are some members of our staff that don't utilize our healthcare, and there's some that do, and not everybody benefits when we make and put more towards the healthcare front.
I have an additional question. Oh, go ahead, Mr. Hossain.
For the employee plus spouse, the employee is paying $641 in this program or plan. Is the $75 included in that, or is there an additional $75 from here?
It's included in the rate structure. So if you were seeing, if this slide showed you employee plus child, it would be a different structure you'd see.
So the 641 is inclusive of the 75.
Right.
Okay.
Yes, Mr. Hodges.
So doing a little scribbling in math, 466 people using the spousal surcharge at $75 a month roughly equates to about $420,000 a year that we recoup. And adding an additional $25 a month on that would gain us around an extra $100,000 a year. So if we change that to $100 a month, then that total goes to about $560,000 a year, assuming no one else drops out from using that because of the increased charges and they decide that's not worth it. So that's just a little bit of napkin math for context on if we increase the surcharge, that's what we're talking about here. Every $25 nets us about $100,000 annually, just for context.
Thank you, Mr. Hodges. Appreciate the math. Any other questions? So if I can summarize, it sounds as if we are willing to see what that impact would be as we're balancing all of the puts and takes.
Yes.
Yes, seeing nods. Okay. Thank you.
Thank you. We appreciate that. So are there any other questions on the healthcare front before we make one more shift to some of the summary totals? Renee, let's talk a little bit about summaries.
All right. So first, looking at revenue, our local revenue is based on the joint agreement adopted in October. That agreement establishes the baseline level of funding available for the fiscal 27 budget, which is an increase of $6 million, unless the board chooses to formally request additional support. And then looking at our state revenue estimates based on Governor Youngkin's proposed budget, we would be looking at an estimated increase of $4.6 million in state funding. And combining that with our local revenue increase of $6 million, we're looking at about a $10.6 million in increased revenue for next year. Then these next couple of slides, we've summarized the expenditure increases that we've been talking about in our budget workshops the past couple of weeks. This one first summarizes compensation and benefits costs that we've been discussing. On the compensation side, these expenditures reflect the continued implementation of the compensation study recommendations. This is part of a multi-year approach to remain competitive, address internal equity, and retain staff. For employees on the teacher scale, the minimum pay increase would be 2%, but it would be an average of 4.5% to 5% over all lanes of the scale. And the unified scale would see an overall increase of 3.5%. The benefit portion of this slide reflects our best current estimate for health insurance costs. The range for healthcare increase is based on a 16% increase, with the lower end representing a cost share of the division assuming 60% of that increased cost, and the higher end is the division assuming 100% of the increased cost. The estimated cost for items discussed related to compensation, benefits, and positions ranges from $12.1 million to $13.6 million. And this slide summarizes additional expenditure increases that we've been discussing. The majority of the items shown here are contractually obligated or required to continue current operations. These include costs that the division is legally or operationally committed to, and they are not discretionary in nature. That would be the New Horizons increases, our insurance increases for workers' comp and liability. Also included on this slide are a small number of optional items, specifically the lacrosse and JROTC programs, as well as certain department level requests are presented as options for board consideration. They're included here to provide a complete picture of all previously discussed requests and to clearly differentiate between required cost and optional priorities. Estimated cost for non-compensation related items ranges from $3 to $3.3 million. In total, the estimated expenditure increase ranges from $15.1 to $17 million if everything we've been discussing over the past few weeks are included in the budget proposal. And when you compare the expenditure increases to the revenue increase amount of $10.6 million, and also factor in expenditure savings from attrition and department reductions, the additional funds needed range from $3.3 million to $5.1 million, which would become an additional request from the localities. And with that, we'd be happy to answer any questions you may have.
Any additional questions? Are there any other items you need us to weigh in on? Or?
Well, I think that it would be helpful for us as we begin to really zero in on February 3rd and releasing an operating budget that I would do publicly on the 3rd is to have a sense of what our comfort level is. I know that there will be additional discussions. Also, that same week, we'll be making a presentation to the Board of Supervisors and City Council. If there is general support for the numbers as we laid them out, then one of the things that we will endeavor to do in the next week or so is to determine what might go into that above and beyond request that we would send to the locality and categorize those things so that there could be some awareness of here's what we can fit into the operating budget and here are the things that we feel like are absolutely essential that we would ask for additional support financially to get accomplished. And at the same time, when we're in Richmond on the 26th, make a case at the state level for additional funding directed back towards education at the state level, which would then reduce the impact of the locality.
Yes, Ms.
I do have
Hurley.
one question. So in people that work for the fire department or police department, what are their health care? Is it 70/30 as well, or are they on something separate?
I am not as familiar with the healthcare split that the county or the city utilize.
Okay.
I can ask that question of my colleagues to kind of get a determination. I'm not sure what the splits are.
Yes, Mr. Hodges.
Going back to Mr. Snow's presentation, the number that we're paying for GLP-1s is about $1.5 million. When we come back to the budget summary on additional funds needed, the lower end is 3.27, let's call it 3.3 million. Taking $1.5 million off of that potentially for axing coverage for GLP-1s or modifying coverage would seem to go a long way in alleviating a little bit of this budget constraint. Am I off base there?
You're not. We've done that. So part of what we're presenting to you this evening at the 16% is also making some fairly specific moves around GLP-1s. So we've attempted to correct for that under the auspices of we were hopeful that the board would be supportive of us looking at ways to help control for that. Again, 16% is a worst case scenario. We're hoping that it is less than that, but we feel like we've got a budget towards that so that we're not left in a lurch as we get into May. Any other feedback for us as we begin to really put the parts of the budget together for you for the 3rd?
Not hearing any.
So Miss Ewing and I will spend some time in the workshop putting together the numbers. I think that based on kind of what I heard this evening, we will develop the operating budget utilizing the data that you have in front of you, and I'll work to categorize some of those above and beyond requests that we would ask of the locality, and you can give me some guidance as we get into the budget discussion on February 3rd about where to place those things. I'll come out of the gate with some initial thoughts on where to place them, and I'm happy to talk about that as we go.
I just have, I guess, one comment, and this was something that I think you mentioned at our last board meeting. And this goes to the additional positions that we're looking at. I just think it's concerning, or we're going to get a lot of pushback on that our student population is maintaining a fairly stagnant level, but we're looking to increase full-time positions by 27 people at this point.
Right.
And so I think we're going to get, I don't know if there's a good justification to say, hey, look, let's increase our personnel by 27 individuals while our student population is not increasing at all.
I understand.
That's going to be a hard sell to a lot of people with this budget, especially when you're looking at, and I understand some of those are transitioning from grants, and so
they're already, right,
it won't be the entire amount, but that's
Right.
1.8 million. So going back to what Mr. Hodges was saying, I mean, if you're looking at the 3-point-something million at the lower end, I mean, that's over probably about half of
Right.
what we would need.
So just as an example, of those 27, 6 are already funded through grants. So those 6 people are in there. So that really drops the number to 21. If you look at the 21, we're asking to put 7 bus drivers back in. We pulled out 5 or 10 bus drivers last year and have staffed up because we can continue to hire folks. So technically those 7 are already real people as well. So I can show you that brand new, not filled FTEs are different than the 27, but for the purposes of that line item, I think you need to be aware that we're talking about 27 FTEs. I think in reality, we're probably talking more about maybe 15 total new people into the organization versus that big number of 27. And I get it. I hear the conversation around you want additional staff, your enrollment's the same. I will say that from my perspective as superintendent, the needs of our students continue to evolve, and we have to look inwardly about how to best meet those needs. So in some cases, we need to consider reconfiguration of current positions, but there are also cases where we need to consider additional positions to continue to provide different types of supports. So I see it in both ways, and we'll look forward to kind of sharing on the 3rd that position breakdown, totally brand new FTEs versus people that we need to bring in from the grants budget, because there is less certainty year over year at the federal level in terms of the grant positions. Thank you.
Any other additional? Well, if not, thank you both, and thank you, Dr. Kiefer.
Yes, ma'am.
We call this meeting adjourned.